Hello and welcome to Medical Dialogues, your daily dose of health and medical news. I am Dr. Nandita Mohan and here is what we have for you all from the world of medicine. This genetic condition that can worsen in pregnancy, even causing fatal outcomes. A systematic review of maternal and fetal outcomes of pregnancy in patients with hypertrophic cardiomyopathy that was published in International Journal of Cardiology, wherein a literature search for studies reporting maternal or fetal outcomes in pregnant women with hypertrophic cardiomyopathy was done. Primary outcomes included maternal death, stillbirth, and even fetal death, while secondary maternal outcomes they include both sustained and non-sustained ventricular tachycardia, atrial fibrillation, heart failure, syncope, cesarean delivery, and preeclampsia or eclampsia. The secondary fetal outcome was preterm birth. A total of 18 studies with 1,624 pregnancies were included, where the incidence of maternal death was 0.2%. The rates of sustained ventricular tachycardia, any ventricular tachycardia for that matter, atrial fibrillation, heart failure and syncope were varied, while postpartum hemorrhage, preeclampsia or eclampsia and cesarean section complications were 2%, 4% and 43% of the pregnancies respectively. Neonatal death also occurred in 0.2% of the pregnancies. Hence, the researchers concluded that women with hypertrophic cardiomyopathy considering pregnancy can be reassured that the risk of maternal, fetal or neonatal death is low. However, they are at risk of several non-fatal cardiac and pregnancy-related complications. How this angioplasty, in other words the percutaneous coronary intervention, is going to affect the vessel function. Both fractional flow reserve and non-hyperemic pressure ratios are widely used to assess the hemodynamic importance of intermediate coronary artery lesions. While the specific merits of each of these physiological indices have been mainly validated in a pre-percutaneous coronary intervention setting, there is still an increasing interest in the use of either the fractional flow reserve or the non-hyperemic pressure ratios to assess the direct impact of stent placement on post-percutaneous coronary intervention physiology. Now, the FAST outcome study is a retrospective cohort study in which the patients were recruited from the P-Search registry. The study is published in the International Journal of Cardiology and it aimed to assess the prognostic value of post-percutaneous coronary interventions and the incidence of target vessel failure, a composite endpoint of either cardiovascular death, spontaneous target vessel myocardial infarction, as well as revascularization at 5 years follow-up. Participants were at an age of 65 years, while 18.2% were diabetic, 29.1% presented with stable angina. The vessels were categorized into tertiles based on post-percutaneous coronary intervention vessel fractional flow reserve, low, middle and upper. The vessels in the lower and the middle tertile were more often left anterior descending and had smaller stent diameters. Additionally, the vessels in the lower tertile had higher rates of target vessel revascularization as compared to vessels in the higher tertile. The researchers hence concluded that lower post-percutaneous coronary intervention vessel fractional flow reserve values are associated with a significantly increased risk of target vessel failure and target vessel revascularization at a 5 years follow-up period. Consequences of late preterm birth and the cardiometabolic diseases associated with it. A new study findings published in the JAMA Network Open suggests that because the cardiometabolic risk score tracks risk from childhood into adulthood, the late preterm and the moderately preterm birth may be an important risk factor for cardiometabolic diseases occurring later in the life. The long-term cardiometabolic consequences of late preterm birth are not well understood till date. To assess whether the late preterm birth and the size for gestational age are associated with cardiometabolic risk in childhood, the study was hence conducted. The retrospective cohort study included around 1,800 children who were born. Participants were excluded if they had conditions affecting their growth, any acute or chronic conditions other than either asthma or high-functioning autism, severe developmental delay, or families who were unable to communicate in English. The primary outcome was composite cardiometabolic risk score, while the secondary outcomes were the individual cardiometabolic risk components. Among the 2,440 eligible children, 87 were born moderately preterm, 145 were born late preterm, 455 were born early term, and 1,055 were born full term. Compared with children born full term, those who were born moderately preterm and late preterm had higher cardiometabolic risk scores. Each additional gestational week was associated with a 0.06 decrease in cardiometabolic risk. In this study, the researchers hence concluded that children who were born late preterm or moderately preterm had a higher cardiometabolic risk. These results did suggest that screening and early life interventions for these children may prevent cardiometabolic outcomes. The risk factors of lower gastrointestinal bleeding. In a recent systematic review published in JAMA Network Open, it reports the risk scores for lower gastrointestinal bleeding. The Oakland score was the most discriminative for predicting the safe discharge, major bleeding, and need for transfusion, whereas the Straight score was the best at predicting the need for homeostasis. Clinical prediction models or the risk scores can be used to risk the stratify patients with lower gastrointestinal bleeding, although the most discriminative score is still unknown. Observational and interventional studies deriving or validating a lower gastrointestinal bleeding risk score for the prediction of a clinical outcome were included. The studies, including patients younger than 16 years or limited to a specific patient population or a specific cause of bleeding, were excluded. 2 investigators independently screened the studies and disagreements were resolved by consensus. A total of 3,300 citations were identified. The Oakland, Strat, the NOBLADS, that is the non-steroidal anti-inflammatory drug use, no diarrhea, no abdominal tenderness, blood pressure, antiplatelet drug use, albumin and disease score, and the bleed were all included in the meta-analysis. The Oakland score was the most discriminative one for lower gastrointestinal bleeding risk score for predicting safe discharge, major bleeding, and the need for transfusion, whereas the Strat score was considered best for predicting the need for homeostasis. Hence, it was concluded that these scores can be used to predict the outcomes from lower gastrointestinal bleeding and also guide the clinical care professional accordingly. That's all for today. Stay tuned to Medical Dialogues for latest updates.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.